Good day. I am Dr. Sunder. I am a heart and lung transplant surgeon from Apollo Hospitals in Chennai. I'm delighted to take part in the third World Congress on Cardiac Imaging and Clinical Cardiology. I did speak just recently, a few minutes ago, on the right ventricle in the role of heart and lung transplantation. The right ventricle can be described as a forgotten child. It has not been receiving its due attention. The left ventricle has hijacked all the attention, quite rightly so, but at the expense of the right ventricle. And it has received a stepmotherly attitude from the healthcare professionals. Of late, with the advent of increasing interest in pulmonary artery hypertension, increasing registries, right ventricle has eventually achieved the motherly care and affection it needs. As quoted by Eugene Braunwald, that right ventricle is no longer a stepchild. So my talk on right ventricle discussed the aspects of right ventricle in the native heart, in terms of end-stage heart and lung disease, and the right ventricle in a transplanted heart. So when you come to right ventricle in the native heart, prior to transplantation in a heart transplant, end-stage heart disease, assessment of pulmonary vascular resistance is most important, and the right ventricular function. If the pulmonary vascular resistance is very high and it is irreversible, an isolated heart transplant will fail, and these patients may need a heart and a double lung transplant. So it's very important you measure the pressures in the lung, the pulmonary artery pressures, and if they are high, we do testings, what we call reversibility testings. We give medications such as nitric oxide, nitroglycerin, milrinone to see if the pulmonary artery pressure comes down. If it comes down, yes, we can still go ahead with the isolated heart transplant. Now coming to native heart right ventricle in lung disease. Lung disease is a little bit challenging because it affects the right side of the heart. So we need to assess and see if the left side of the heart is normal. If that is the case, no matter what the degree of weakness in the right ventricle, it will heal after the double lung transplant. So in such patients, double lung transplant alone, leaving the native heart behind, is an operation of choice. However, there is a caveat. To look after these patients in the postoperative period is quite challenging because the native left ventricle was not used to a high blood flow. It became small, stiff, and when you do a transplant, the blood flow becomes high and the left ventricle is unable to cope. So the management in the ICU is challenging because what the left ventricle wants is not good for the right ventricle, and what the right ventricle wants is not good for the left ventricle. Centers which recommend a combined heart and double lung transplant instead of heart and double lung transplant. Now, is there a way in between these two? Yes, the Hanover group in Germany made use of the ECMO they had during the operation, deliberately used it 5 or 6 days after the operation, allowing time for the left ventricle to get used to increased flow, and that helped and got good results. Now coming to discussion of right ventricle in transplanted heart, about 30% of patients have right ventricular dysfunction after heart transplant. It could be because of various factors, but when the pulmonary artery pressures are normal and there are no rejection or infection, it's called a primary graft dysfunction. There are ways and methods of treating it by fluid balance, nitric oxide, inotropes, and sometimes you might need mechanical circulatory support like ECMO. Other causes of right ventricular problems after heart transplant could be rejection, which could manifest as a right ventricular dysfunction, which could be diagnosed by a heart muscle biopsy and appropriate steps taken. Thank you for your attention.